I think the main focus is going to be on the clinical data, obviously, and the update of the phase 1A clinical trial, looking at, on the one hand, the highest dose level, the cohort 4, where we now have more follow-up of these patients, and also what we're calling the open label extension. So what happens is the earlier patients that were enrolled on the study, they had the option of continuing on treatment with ATA188 many months after they complete the initial part of the study. So we'll be able to provide safety data and some efficacy data on that long-term follow-up as well. I think it was very well tolerated, and the good news is that we are not seeing that even with the longer term dosing of patients with these cells going out to 21 months, 24 months, we're not seeing augmentation of safety issues. So one of the aspects of ATA188 is it's a very specific treatment. So these T cells are really directed against only EBV expressing infected cells. And so we don't have a lot of off-target toxicity because of that. So a lot of cell therapy, whether it's CAR T or whatever it may be, you can see neurological symptoms, you can see what's called cytokine release syndrome, and so forth. And we really don't see those types of effects with our treatment, because again, the specificity of our EBV T cells, they're not directed against the patient's own self-antigens, if you will. A couple of other comments about the goals of the phase 1A study. Certainly safety, as you mentioned. The other aspect is really finding the right dose of these cells that we can do further development with. So as we showed earlier this year, that we are seeing incrementally more early signs of efficacy at higher dose. So again, the goal of the study here is to isolate the right dose to go forward with, where we saw the cohort 3 dose and cohort 4 dose were safe, but they were also potentially driving more efficacy than the cohort 1 and 2. Now, in terms of early signs of efficacy, we are encouraged by what we're seeing on the clinical trial, because when you get into cohort 3, we are seeing in some of these patients sustained disability improvement, or what we call SDI. So that is a special measure where you're actually looking at the physical performance of these patients with multiple sclerosis. And there's also the sustained aspect. So this is not just one point in time where you're saying that patient is doing a little bit better today, but the sustained piece means that you have to show benefit at 6 months, and then you have to show benefit at 12 months. And that's really clinically meaningful if you can show that this is a longer term improvement. But what we saw at doses, the doses in cohort 3 and 4, is that we saw a number of patients with sustained disability improvement. And the new data here for cohort 4 is that the 2 patients that had 2 out of 6 patients who had sustained disability improvement at 6 months now also show it at 12 months, and that's very meaningful. The other thing that we saw an early look at was that there were 2 additional patients in that cohort 4 that were showing disability improvement at 12 months, which they hadn't shown before. We can't say it's sustained because it's only one time point, but we are looking at the next time point, which will be at 15 months, and perhaps those patients will also convert. So the big message here is that patients who've achieved sustained disability improvement at any time point have maintained it at all future time points. And that's the case for cohort 1 patients, cohort 2 patients, cohort 3 patients, and now we see it for cohort 4 as well. And we do see a higher proportion of sustained disability improvements in the cohort 3 dose and the cohort 4 dose as well. So I think those are very encouraging. The other thing that we are reporting at the meeting is actually some other measures. So I spoke a lot about sustained disability improvement, and but there are other measures that we looked at as well. And so one is the fatigue severity scale, or FSS, and we actually broke it out by whether or not patient had a sustained disability improvement or not. And we actually see the patients who had improvements in SDI actually had better fatigue scores as well. We also looked at MSIS, or MS Impact Scale, which is really a combination of 20 physical measures as well as 9 psychological measures. And here we're also seeing a trend, a statistical trend, that the patients who had SDI improvement, that they actually had better MSIS scores as well. And then additionally, we looked at MSWS, or MS Walking Scale, where again, the patients who had SDI actually had improved walking scale as well. And these are well-established metrics. That's an MS validated patient-reported outcome measure. Then we also did the 9-hole peg test, which also showed some directional favoritism for the SDI patients. And then we also looked at whole brain volume by MRI, which again is a radiographic assessment where we saw numerically that there was less brain volume loss in the SDI patients. The reason why I think this data is important is it really supports our SDI findings, because SDI is one measure, but here you have 5 other independent measures that are also showing the same directionality. And then the last thing I want to comment on are the open label extension data. So what we're showing here at the ECTRIMS-ACTRIMS meeting is that we have 6 patients that rolled over from the official study into the open label extension. And these patients now got bumped up to the cohort 3 dose. So that includes the cohort 1 and 2 patients, where they now got a boost of dose when they went into open label extension. And of these 6 patients, we saw essentially excellent SDI outcomes for all of these patients. So again, that same theme, that if you get an SDI, you maintain it. And if you get a higher dose, you probably get more SDI as well. And so of the 6 patients that we describe in the OLE, 3 of the patients had SDI at 6 months and 12 months, which was maintained at 15 months, which is meaningful. A 4th achieved SDI during the OLE, which is really interesting, right? So this was a patient who was in cohort 1 that we started redosing at month 21, and then there was improvement, and then at month 24, we could actually call this an SDI patient because there were 2 consecutive time points. So that patient actually achieved SDI on the open label extension, and then we had 1 patient who maintained SDI between 6 and 8 months. 6 and 18 months. So all 6 patients are actually showing good outcome, and importantly, no new safety concerns, because that's the other aspect. As we hopefully get this drug through development and hopefully closer to getting the drug available to patients, we want to make sure it's safe long term. And the OLE experiment certainly shows us in this small number of patients that there are no new safety signals with doing that.